in the coffee break, I was asking the people who were at the back, I said, are you able to see the slides? They said, yes. I asked them, are you able to hear me? They said, yes. Any problem? Yes, we are not able to see you though. So, because with minuscule structure of mind, visibility could be a problem also. Anyway, when you do CTOs, you also acquire mastery over non-CTO lesions, because some of the techniques which are used in conquering a CTO would be quite helpful in situations like tortuosity, hard lesion, non-crossable lesions, non-dilatable lesions, etc. I think a CTO, you must prove first of all, when should you do a CTO? 3 things are required before you address a CTO. Number 1, you must show that that CTO is responsible for the symptoms of the patients, namely angina. 2, that if not, then it should be related to a left ventricular dysfunction, the ischemia-related dysfunction in relation to the CTO. And thirdly, you yourself must make a self-assessment that would you be able to successfully do this CTO or not. Without that, I think you should not. If your success rate is 70% and above without producing myocardial infarction, death, then I think you can make an attempt to do a CTO. So dedicated CTO hardwares are microcatheters, dedicated wires, of course balloon and stents, and those are lesion specific and anatomy specific. Let me illustrate what do I mean. You see this particular case, the origin, the right coronary is anomalous in origin. The vessel has not been adequately and properly cannulated. The proximal segment is so very proximal that just in case if I need for support by taking, let's say, an anchoring balloon, that may not be possible. The entry point is not very clear because a couple of branches are coming out at that point of time, at that point of anatomy. Missing segment, now it's important. If the missing segment, that means if you have outlined the proximal segment and the distal segment by contralateral injection, and if they move in opposite direction, then the intervening missing segment is curved and tortuous. I repeat, if the proximal segment which you have seen by antegrade injection and the distal segment you have seen by the contralateral injection and the missing segment between the two, the antegrade opacified segment and the distal segment, if they move in opposite direction, the intervening missing segment is tortuous and curved. All right. Okay. The importance of bilateral injection is that very often you will find that the CTO is much shorter than what you anticipate when you do the bilateral injection. And here again you see that the antegrade injection is not collateral, it is not coaxial. The catheter is actually not selectively engaged, and therefore this you know very well that you can't use the same. But when you use an AR2 catheter, now it has selectively been engaged, and you can see that CTO is a little bit easier than what you thought initially because it's outlined well. Microcatheters. What is the function of microcatheters? So many times people ask me, how about over-the-wire balloon? No, it's not a substitute for 2 reasons. Over-the-wire balloons have a larger profile. And number 2, I think the over-the-wire balloons, we use it sometimes to save the cost, but that is not so because over-the-wire balloons, they have a heart. And second thing, the microcatheters, the inner lining is with PTFE coated, Teflon coated. So therefore, it has a smoothness and the wire movement is sleek. Second thing, the space between the microcatheters lumen and the wire is just minimal so that it hugs the wire quite reasonably well and do not allow it to dangle. So you should use microcatheters and not the balloons. All right. What does it do? It facilitates wire and gives the support. It gives you an opportunity to change the wire very easily, and you do not have to keep on re-entering the coronary artery again and again. With a microcatheter, you can do a super selective angiography. it can increase the tip load. When you bring the microcatheter closer to the tip of the wire, the force, the power of the wire is enhanced, can increase the tip load exponentially. Lower crossing profiles than angiographic catheters and balloons, and better torque and pushability, and these are the properties of microcatheter. There are two which I have addressed, three: Fine Cross, Corsair, Crusade, and the latest is Corsair Pro XS. Corsair Pro XS is now my preferred but microcatheter. Before it came in, Fine Cross was my preferred microcatheter. And why Fine Cross was my preferred microcatheter? Because A, it has a tapered tip. 2, the entry profile was very small, 0.01718, and therefore snugly fitting and easy crossing profile, allowing the penetration very easily. Okay. Carvel is a better profile, but Carvel cannot be rotated. If you rotate the Carvel, it will fracture, and that will create a problem. Corsair Pro XS, Fine Cross, they can be rotated, torqued. You can't do that with Carvel. Okay, so the resistance for rotation, and that is what will happen if you attempt, so do not rotate the catheter. CTO wires, we must know all about. So many CTO wires, but basically we must achieve the penetrating efficiency. What is penetrating efficiency? Penetrating efficiency is dependent on three factors. The tip, the surface area of the tip. For example, some wires are tapered. Fielders 0.009, Conquest Pro 0.009, Conquest Pro 820 0.008. So these wires which are tapered, they have a better penetrating efficiency. Tip load. What is a tip load? The wire which can bear the weight when it is straight and yet not bend. For example, on a wire which you hold straight and put a load of 12 grams on the top of the wire and yet it does not bend, the tip load of the wire is 12 grams. Combined together, side lubricity. If the wire is hydrophilic or polymer coated, it is very easy to slide. So combined together, the sliding property, the tip load, and penetrating efficiency by tip surface gives you a total penetrating force, which I think is proportionate and based on the three properties which I just enumerated. Recently, one more wire has come. That is called Suho wire. Suho wire's tip load is very, very low, 0.3 grams only. And this wire is specifically used for entering the septal channels for retrograde CTO procedure. All right, so same case now I'm showing you. So now here we see that the wire is, the proximal artery is very adequately cannulated, and I have used the wire, and this wire, having entered up to a certain distance, is not able to cross any more further. So I started to think about using Gaia 2 wire and not Conquest series, because Conquest series wires are not easily torqueable and are meant for straighter segment. Anywhere if there is a curvature, they will easily create a perforation or dissection, and therefore Conquest Pro is meant for a specific purpose. So finally, the Gaia 3 wire entered, but when we check by the contralateral injection, it is trying to enter the side branch. Is it seen clearly? That is trying to enter the side branch. This is the side branch. Okay. So I tried to change the direction with a Miracle 6 wire, but it did not happen. So I decided to go into the side branch, confirmed its location. Yes, I am correctly in the side branch, and dilated the side branch. When you dilated side branch at the level of the fibrous cap, the distal entry point, there is a dissection there. That dissection allows the side branch technique here, illustrated diagrammatically, creates a dissection which can become then a penetrating point in the target artery in its distal segment. This is called side branch technique. One can profitably use this technique where it is available, and where the side branch, the main branch, distal main branch segment is difficult to enter. Then I dilated that area with V1.2 and then followed by 2 millimeter balloon, and then brought the microcatheter back, and I can now very clearly see the artery. Now it is very easy to enter. Brought the microcatheter back and made an injection through the microcatheter and saw that there is a visibility of a distal segment. Then whisper extra support wire successfully crossed the right coronary artery and dottering with the microcatheter, and then we placed 2 stents, one by one, distal first and then proximal, and this was the final result. So this side branch technique is worth learning and can be useful when you have one more thing, parallel wire technique. What is a parallel wire technique? Many times you come to know that your wire has entered a wrong dissection and a wrong lumen, or it is subintimal. Only you come to know when you have opacified the distal segment contralaterally injected. You realize that wire is not going into the correct passage, but it's wrong. So then how do you do? Let me show you the principles. First of all, penetration of the proximal fibrous cap and CTO vessel is straightened up. The wire is entered into the false passage. Then you have to use a second wire without removing the first wire. You may make 1 or 2 attempts to correct this by rotating the wire, but if you do more frequently, only the false passage will start enlarging and making the true passage smaller and more difficult to enter there. So then you take a second wire. The second wire should be a little stronger than the first wire in tip load. It has a more angulation and it should enter beyond proximal to the point where the wire has entered into the false passage. The second wire is helpful because first wire has blocked the passage. It is also gives you a geographical mapping, and thirdly it gives you some support. The second wire running parallel, and it comes down here and enters the true lumen. So this is the principle of parallel wire technique. So here again, the first wire has a smaller angle, second wire has to have a little bigger angle because it has to re-enter and enter into the true lumen. The angle, secondary angle, also is a little bigger, and the second wire should be stronger. So let me show you the example of parallel wire technique. This is a stumpless CTO of LAD. I can't see anything. So there are 2 ways to approach this. A, either completely retrograde. B, I use an IVUS and try and find out that where is the carina, and if the carina is found, then I find that is the suspicious area where it could be arising, the LAD, and try to penetrate under the guidance of IVUS. Or thirdly is that after having found by multiple injection a protrusion, a stump, I decided to enter with Fielder XT-A wire, pilot wire, but both of them have gone into the false passage. So I said, let me go and try the retrograde approach. The retrograde approach also had failed, and now parallel wire technique with again 2 wires, but both the wires are in the false passage. The third wire is only a reference wire going into the ramus. So these both wires were in the false passage. So then the next day decided to do again the parallel wire, and we used a Conquest Pro wire. The retrograde technique which I showed you is failed. Here is the retrograde coming from the right coronary, septal, and trying to enter, but it came to a broomstick appearance here. So we can't do it. And finally, the Conquest Pro wire entered. Subsequently, I don't have a slide, but then I think the cannulation followed by stenting, recanalization of the artery, and revascularization was easy. Sometimes the artery is calcified, curved, and tortuous. And the distal segment also is calcified and tortuous, like as in this case. First of all, it is traveling upwards, so little bit shepherd's crook kind of an appearance that makes the entry a little more difficult. There is a large branch available here, which I can use as an anchoring balloon technique so that I get the support to this guide catheter, and then I start it. So filter XTR, Gaia 2, not crossed. Ultimately, cyan black wire successfully crossed. Now why? Cyan black is a less tip load, only 0.6, but it is a tremendous lubrosity because it is polymer coated. And it has a very high torqueability. If you find a correct microchannel, then I think even a soft wire can enter. But after this, the microcatheter would not enter. So I had to take an anchoring balloon technique. One or two words about anchoring balloon. You must always use the useless or clinically insignificant vessel. Here, this is a sinus node branch. Intermittently, I might have to deflate it, not to produce sinus node ischemia. Try and go as much distally as possible and anchor it with an appropriately sized small balloon at not more than 6 or 8 atmosphere. Thereafter, I tried to enter and produced a serial balloon dilatation, done, and delivered the stent, and that was the final result, which I think, I'm not sure, I'm sorry about it. But now this is an RCA CTO. Sometimes it looks very simple. This is a short CTO, and you think it's going to be a cakewalk and will be done in no time. After the bilateral shoot, you realize that yes, it's easy, small segment, straight segment, but it was extremely hard. BMW with microcatheter to bring the microcatheter up to the surface, up to the entry point, and then change to filter XTA wire. And after that, the fine cross and 1.2 balloon, nothing crossed. It would just not cross. Anchoring balloon technique did not work. Nothing would cross still. So then what to do now? I decided to take tonus. Tonus is that microcatheter which is 8 strong wires are interwoven in the form of a rope, and when you rotate it clockwise and anti-clockwise, it slowly enters and creates the patency, and little patency is good enough to allow the microcatheter to go, and subsequently you can address the CTO after regular balloon dilatation, and this would be the final result. 2.5 40 millimeter long stent, and this was the final result. In case if the tonus fails, then you have still 2 options. Laser, and occasionally we had to resort to laser, but the laser might not be easily available in many labs. But I think if the tonus doesn't work, what you can sometimes do, wedge it as much as you can and then change over to rotawire and then do a rotablation. Sometimes you have to have a primary retrograde approach, and this is possible. This is required to be done when there is a total occlusion at the level of stump, like LAD stump. So here you go into the donor artery, study the collaterals. These are straight collaterals. If the collaterals large and straight, they are very good. Class 3, according to Werner's classification. If they are tortuous and small, they are bad. But between the two, the size and the tortuosity, I would say the one which is smaller but less tortuous is still preferable. The regular wire has been brought up to here. Over this, I thread the microcatheter. After threading the microcatheter, I make an injection through the microcatheter. And I find that there is a broomstick kind of an appearance here, out of which I will have to select that channel which connects accurately and goes forward. So I change the wire to Sion wire This is a Shaurin wire which has gone all the way up to the proximal fibrous cap, but Shaurin wire is not powerful enough to penetrate the distal fibrous cap of totally occluded LED, or the, let me say, the stump of the LED in this case. So it can't. So therefore, I pass a Corsair, an advanced retro delivery right up to the total occlusion. Take a reference wire. There is a curve here. One has to be careful. When we took a lateral, we found there is a curve here. Enter that. Enter into the parent vessel. And in the parent vessel, the wire is trapped with the balloon. And we create a passage by the microcatheter traveling up in the direction towards the ostium of the LED. Change the wire. And come now, integrate now from the contralateral groin. I can come back because the wire has come out from the contralateral groin through this catheter, other way. And then dilate with the balloon. Take a regular wire then and dilate it, and this is dilate more, and this is the final result. So I think various techniques are to be applied. And now, I should say that of late there has been growing interest in the drug-eluting balloons. The advantage of drug-eluting balloons is obvious because it requires, it eliminates the technique for delivering the stent. There is no metallic jacket. The anti-proliferative effect of the drug continues for more than 6 weeks, and the limitations of CTA angio, which I think is difficult to give any information in a stented artery, and I think it is eliminated. The drug is very often found in the tissue for 3 months. And you know very well that the complications of benign neointima, neointimal hyperplasia, stent restenosis, and stent thrombosis are eliminated. And I think the studies are now ongoing, which one to use, sirolimus or paclitaxel. Dr. Colombo believes that if you have prepared the lesion well and you have released the elastic recoil by cutting balloon and without dissection and a good TIMI3 flow, I think a drug balloon will take over the stent, and you might not have to use a stent in future. This is especially true if you are dealing with a bifurcating lesion, CTO, and the distal lesions. Thank you very much.
Thank you very much, sir, for your very nice and enlightening lecture.
Well, I must say one thing. Somebody asked me, Prakash, what's your achievement in after so many years of practice? You treated hundreds of patients. That's fine, everybody treats. But I feel that my students like you, Prashant Sahu, Tejas Patel, in the various parts of the country, and even outside the country, in the United States, keep on doing practice and extending their services to hundreds of patients is my investment which has grown. Okay, your question, Prakash?
Any questions for the sir?
Great talk. So I wanted to ask you, so in some of the cases, if we have only antegrade options, you're doing parallel and you're not successful, there are no retrograde options. So if you do a star, for example, in a RCA, you do a star technique, you enter the distal RCA balloon, the whole segment, do kind of an investment. So in how many cases in your vast experience, when these patients come back, you feel that the whole of the RCA is now, it's healed and you don't require stents or you require very limited stents. So what is the follow-up of these patients who are unable, you are not able to open the CTO, you do a star and leave the patients alone and bring the patients back. So how many of these patients, how do they do on follow-up?
I'll change your question a little bit. Whenever the wires entered the false passage beyond the distal fibrous cap, within the missing segment, true, false, true, doesn't matter. Not only that, but you can't even know. You can't know because you don't know where you are going. But When you come to distal fibrous cap and you see that the wire has migrated outside, you know you are in the false passage. And from where, we do not know. Now, 2-3 approaches. Star is given up, but ADR I'll talk of. Antegrade dissection and re-entry. What they do is that the stingray balloon, and with that, they enter the wire. Any wire will do, but they have the specific wire which you keep on rotating fast and do this way. Americans feel that is faster and more effective. Although you travel for a long segment into the subintimal passage, what is its impact on re-entry? I personally feel re-entry rate should be higher. When you are true to true, from proximal to distal, I think you have a benefit of a much less restenosis rate. I do not have any data, but it makes to my logic. It sounds more logical that if you are true to true, then obviously you have reconstructed the real anatomic form of the artery originally.
Thanks for excellent talk. Just regarding the DCB, what we believe is indication in instant restenosis, osteal lesions or side branch lesions like that.
Yeah.
Apart from that, what opinion on de novo lesion and CTO and ACS regarding the DCB?
About the two things about the CTO. Yes, compared to a non-CTO lesions, CTO lesions have a higher restenosis in general. Rotablated lesions have also higher restenosis no matter what you use in general. But I think because in Andreas Grunzig's word, the restenosis is not a complication, it's a sequelae. Many operations are done twice. Hernias are done twice. Varices are done many times. Cataract is also sometimes done with after cataract. So he thinks that as long as the patient is available to you for the further treatment without any damage, it should not be hated. What do you prefer? 2 sticks in the groin or 1 large 6 inches incision on the chest? That the patient has to decide. Okay, now regarding your question.
DCB de novo lesions.
We do not know, but now Dr. Colombo, when he came in, I attended his lecture, he has a series now, and he has shown that the DCB and the comparing with the conventional treatment with the drug-eluting stand, he has been finding comparable results. Okay.
Thank you so much, sir.